Hello students, welcome to today's session on the lifestyle modifications and diet for hypertensives. Hypertension is a common public health problem in many countries. Untreated hypertension leads to many degenerative diseases including congestive heart failure, end-stage renal disease and peripheral vascular disease. It may remain asymptomatic for years and cause a sudden fatal event. The World Health Organization has estimated that high blood pressure causes 1 in every 8 deaths worldwide, making hypertension the third leading killer in the world. The emphasis on lifestyle modification has given diet a predominant role for both primary prevention and management of hypertension. Every individual has blood pressure, which is necessary to move blood through arteries and to provide oxygen to tissues of the body. Hypertension is elevated blood pressure. World Health Organization defines hypertension as a condition in which systolic pressure exceeds 160 mmHg and diastolic pressure exceeds 95 mm mercury. With diastolic pressure of 100 or more, therapy should be initiated with drugs as well as diet. High blood pressure is not a disease, but only a symptom indicating that some underlying disease is progressing. Hypertension impairs the pumping function of the heart and, if untreated, damages the heart, brain and kidneys. Stroke occurs more often in patients with high blood pressure. The main objective of this module is to understand the impact of lifestyle modifications and dietary guidelines for hypertensives. Now, let us look in detail about the primary prevention of hypertension. The goal of hypertension management is to reduce morbidity and mortality from stroke, hypertension associated heart disease and renal disease. Three primary objectives to look in for the lifestyle and dietary modifications of hypertensive patients are: first, to identify the possible causes; second, to assess the presence or absence of target organ disease and clinical cardiovascular disease, and to identify other cardiovascular disease risk factors that will help to guide the treatment. Changing 4 modifiable factors such as overweight, high salt intake, alcohol consumption and physical inactivity has documented the efficacy in the primary prevention and control of hypertension. Weight history, leisure time physical activity and dietary assessment of sodium, alcohol, saturated fat and caffeine are the components of the medical history. Lifestyle modifications are definite therapy for some and adjunctive therapy for all persons with hypertension. Depending on the risk group, 6 to 12 months of compliant lifestyle modifications should be tried before drug therapy is begun. Even if the lifestyle modifications cannot completely correct the blood pressure, they will help increase the efficacy of pharmacologic agents and improve the cardiovascular disease risk factors. Management of hypertension requires lifelong commitment. First, weight management is a crucial part of the hypertension. The effectiveness of weight reduction has been well documented in both mild and severe hypertensives. The hypertensive patients who weigh more than 115% of ideal body weight should be placed on an individualized weight reduction program that focuses on both hypocaloric dietary intake and exercise. In the trial of anti-hypertensive intervention and management, the goal for energy intake to facilitate the weight loss was 25 kilocalories per kg minus 500 to 1000 kilocalorie daily to produce a 0.5 to 1 kilogram per week deficit that would reach a total weight loss of 4.5 kilograms. This modest loss will not only lower the blood pressure, but often will normalize blood lipid and glucose. The greater the weight loss, the greater the blood pressure reduction. Some stage 1 hypertensives achieve normal blood pressure by weight loss alone. Another benefit of weight loss on blood pressure is the synergistic effect with drug therapy. In subjects who lost weight and were taking antihypertensive drug, lowering of blood pressure was greater than those taking the drug alone. Therefore, weight loss should be an adjunct to drug therapy because it may decrease the dose or number of drugs necessary to control the blood pressure. Furthermore, weight loss lowers blood pressure significantly more than low sodium, high potassium diet because weight loss and exercise increase the insulin sensitivity, lowers the levels of triglycerides and raise HDL cholesterol. This combined intervention is also recommended for treating dyslipidemic hypertension. Once weight is lost, the maintenance is critical. Unfortunately, relapse and weight gains are common following the weight loss. Some factors associated with effective weight management are exercise, positive self-statements related to weight reduction efforts, self-monitoring activities and problem-solving skills in lieu of eating during stressful times. The next is alcohol consumption. 5 to 7% of the hypertension in the population is due to alcohol consumption. 3 drinks per day is the threshold for raising blood pressure and is associated with a 3 mm mercury rise. The alcoholic consumption must be limited. Let's move on to the importance of physical activity. Less active persons are 30 to 50% more likely to develop hypertension than their active counterparts. Individuals with medium to high levels of physical activity are protective against developing stroke. Walking reduces blood pressure in adults by an average of 2%. And aerobic exercise reduced blood pressure an average of 4 mm mercury for systolic and 2 mm mercury for diastolic pressure irrespective of body weight change. Thus, increasing the amount of physical activity of low to moderate intensity to 30 to 45 minutes most days of the week is an important adjunct to other strategies for the primary prevention of hypertension. Obese and overweight hypertensive patients should strike for 300 to 500 kilocalories expended in exercise per day or 1000 to 2000 kilocalorie per week to promote weight loss or weight control. Because exercise is strongly associated with success in weight reduction and weight maintenance programs, any increase in activity level should be encouraged. Moving on to the diet for hypertensives. Principles of the diet involves low calorie, low fat, low sodium diet with normal protein intake is prescribed. The dietary management. Earlier, Kempner's rice fruit diet was suggested for hypertension. This diet was very restrictive and deficient in many nutrients. The requirements include energy. An obese patient must be reduced to normal body weight with low calorie diet. About 20 kilocalories per kg of ideal body weight are prescribed for a sedentary worker and 25 kilocalories per kg of body weight for moderate active worker. Alcohol consumption should be reduced. Moving on to protein, a diet of 60 gram protein is necessary to maintain proper nutrition. In severe hypertensives, protein restriction is to 20 grams as advocated by Kempner may be necessary as a temporary measure since protein foods are rich in sodium. The next is fat. The vegan diet tends to be higher in PUFA among other nutrients and lower in total fat, saturated fatty acids and cholesterol. Polyunsaturated fatty acids are precursors of prostaglandins whose actions affects renal sodium excretion and relax vascular musculature. Thus, an effect on BP is plausible. Both the amount and the type of fat have been studied with respect to BP. It is shown that supplementation of large doses of fish oil can give a modest reduction in systolic and diastolic pressure, especially in older hypertensive persons. As they are prone to atherosclerosis, it is advisable to avoid a high intake of animal or hydrogenated fat. About 20 gram vegetable oil is permitted. The next important is carbohydrate. Complex carbohydrate is of great help in the management of high blood pressure. The other very important is sodium salt restriction. Epidemiological studies of population support an etiologic role for salt in hypertension development. Primitive societies in which the intake of sodium is low experience very little hypertension and increase in blood pressure with age that commonly occur in industrial areas does not occur. Hypertension is prevalent and stroke is the leading cause of death in countries with high salt consumption. The strength of the relationship between salt consumption and blood pressure is stronger in older people, in those with the family history of hypertension and in those with high blood pressure at baseline. Reduction of 2 mm mercury in blood pressure is associated with a 17% reduction in the prevalence of hypertension, 6% reduction in coronary heart disease and 15% reduction in stroke and transient ischemic heart attacks. Increased intake of sodium in diet leads to increased intravascular volume and thus increases cardiac output, elevating blood pressure. Also at the cellular level, increased intracellular sodium is exchanged for increased intracellular calcium with its potent effects of augmented vascular tone and vascular hypertrophy with resulting persistent hypertension. Moderate salt restriction is recommended for treatment of hypertension. The restriction is for salt because the chloride ion with sodium raises the blood pressure. Decreased sodium and a decrease in the sodium potassium ratio in the diet is preferred. Moderate restriction of 2 to 3 gram per day reduces diastolic pressure to 6 to 10 mm mercury and enhances the blood pressure, lowering the diuretic therapy. In stage 1 hypertension, this level of salt restriction may be sufficient to normalize blood pressure. Patients who require drug therapy also need salt restriction for enhanced drug efficacy. Adherence is better for less restrictive salt reductions. Therefore, more severe salt restriction is not necessary unless congestive heart failure is present and 3 grams of sodium is recommended. Most dietary salt comes from processed foods and eating out. Changes in food preparation and processing can help patients reach the sodium goal. A sensory study showed that commercial processing could develop and revise recipes using lower sodium concentrations and reduce added sodium by 30% to 50% without affecting consumer acceptance. American Heart Association prescribed 2 gram for mild and 1 gram sodium for moderate levels of hypertensives. Most of the studies have shown that sodium restriction accompanied by weight reduction can effectively control mild and moderate arterial blood pressure. Pregnant women with toxemia need a moderate rather than low salt intake. Potassium. Potassium's role in hypertension is actually the result of a complex interplay with sodium, calcium and magnesium found in all living cells and in blood. For example, low levels of potassium cause the body to retain sodium and water, and this can elevate blood pressure. Research suggests that the risk of stroke, a common consequence of high BP, relates inversely with the amount of potassium in the diet, and the lowest risk is among high potassium low sodium group. About 3,500 milligram of potassium is required daily. Fruits and vegetables should be taken liberally to meet potassium requirement. Next is calcium. Some preliminary studies have shown that as the intake of calcium increased, the incidence of hypertension declined. Calcium is involved in the control of the strength with which blood is pumped by the heart and with the amount of resistance in the flow of blood in the veins and capillaries, both of which contribute to BP. Next is magnesium. Magnesium is a potent inhibitor of vascular smooth muscle contraction and may play a role in blood pressure regulation as a vasodilator. An inverse relationship has been reported between dietary magnesium and blood pressure. Now, let us look into DASH diet. Dietary approach to stop hypertension. Diet is used for both preventing and controlling high blood pressure. Successful adoption of this diet requires many behavioral changes, twice the average number of daily servings of fruits and vegetables and dairy products. According to DASH, the following diet may bring about a healthy reduction in blood pressure. First, high amount of fruits and vegetables, inclusion of fish, inclusion of low fat milk, reducing the fat intake, reducing the sodium. Studies have shown that high intake of fruits and vegetables results in low mortality among those with stroke. Low levels of dietary flavonoids are associated with the highest risk of stroke. Fiber and folic acid have also been associated with protection against stroke. Green leafies and cruciferous vegetables and citrus fruits in particular are found to be protective. Other factors includes medications. A number of medications either raise blood pressure or interfere with the effectiveness of antihypertensive drugs. These include oral contraceptives, steroids, non-steroidal anti-inflammatory drugs, nasal decongestants and other cold remedies, appetite suppressants and antidepressants. Pharmacologic treatment. If blood pressure remains elevated after 6 to 12 months of lifestyle changes, antihypertensive medications are started. Most patients with hypertension more severe than stage 1 hypertension require drug treatment. However, lifestyle modifications are still a part of therapy even when drugs are used. The standard treatment for hypertension includes diuretics and beta blockers, although other drugs are equally effective. All these drugs can affect nutritional status. Diuretics lower the BP in some patients by promoting volume depletion and sodium loss. However, thiazide diuretics increase urinary potassium excretion, especially in the presence of high salt intake, thus leading to potassium loss and possibly hypokalemia. Except in the case of a potassium sparing diuretic, Additional potassium is usually required. Next is the treatment of blood pressure in older adults. More than half of the older population has hypertension. This is not a normal consequence of aging, but cardiovascular disease risk in older adults is 2 or 3 times higher than in the middle-aged population. The lifestyle modifications discussed previously are the first step in treatment of older adults, as with younger populations. Various studies have proved that losing weight and reducing the salt intake can lessen or eliminate the need for drugs in obese, hypertensive older adults. Severe sodium restrictions are not adopted because these could lead to volume depletion in older patients with renal damage. To summarize, weight control, physical activity and low fat, low sodium diet lowers the blood pressure as well as prevent or control hypertension. Thank you.